Welcome back to the Deep Dive. Our mission today is, well, it's pretty fundamental. We're going to cut through the jargon and really redefine a topic that affects every single one of us: health literacy in the U.S. Because if you think this is just about whether or not you can read a pill bottle, you are frankly about 10 years behind the national conversation.
That's the perfect way to frame it. Yeah. We've synthesized a stack of sources that show a really radical recent transformation in how public health and policy experts are viewing this.
A transformation how?
Well, the traditional model, the one that often defaulted to blaming the patient for not understanding complex medical stuff, it's being officially dismantled. The conversation has moved squarely from sort of fixing the individual to fixing the system.
Right. Okay, let's unpack this then.
Yeah.
The goal here is to synthesize the research, the federal policies, the newest tools, basically everything that reveals how the focus shifted away from individual deficits and towards organizational accountability, systemic fairness. And this knowledge is crucial because it really changes how you, the listener, should think about interacting with your own healthcare system.
And before we even get into definitions and history, we have to start with the cost. Because this shift, it doesn't happen in a vacuum. There's a huge financial driver here. Limited health literacy is a massive quality and safety issue. I mean, huge. And the research estimates the adjusted annual cost to the U.S. economy. It's driven by inefficient care, redundant care, crisis care.
What kind of number are we talking about?
It's as high as a staggering $349 billion annually.
Whoa, okay, $49 billion.
Billion. With a B.
That's not just wasted money, that's the cost of confusion.
Yeah.
Right? The price tag on preventable ER visits.
Precisely. It's the expense of treating chronic conditions that spiral out of control because instructions weren't clear. It's medication non-adherence. It's an overwhelming financial burden.
Yeah, that single number should grab the attention of, well, every hospital CEO, every policymaker, every taxpayer, really.
It absolutely should. If you want to know why federal agencies are pouring resources into this, that price tag is a big part of the answer. It's a systemic economic failure we can't ignore.
Okay, so the cost is enormous. Let's set that aside for a moment, though we'll come back to it. Before we talk fixes, we need to understand how the experts decided the system, not the patient, was the real problem here.
Right.
Let's dive into that profound paradigm shift.
Okay. To really appreciate the scale of this change, you have to look at the old framework. For decades, the foundational definition came from the U.S. Department of Health and Human Services, specifically their Healthy People 2010 and 2020 initiative.
Right, the big national health goals. And what does that old definition emphasize? What was the focus?
It framed health literacy as, and I'm quoting here, the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions.
That language is really telling, isn't it? Especially that word, capacity.
Exactly. That older language, it implicitly placed the main responsibility, what we might call the burden of understanding, squarely on the individual, on their inherent intellectual ability, their educational background, their capacity.
So if a patient didn't understand their discharge instructions or how to take their meds,
the system often defaulted to a patient-blaming model. It sort of allowed organizations to shrug and say, well, we gave them the information, their capacity just wasn't sufficient to absorb it.
that seems incredibly unfair, especially when you consider just how complex and jargon-filled most healthcare communication actually is.
It was profoundly limiting, yeah. And it let organizations off the hook for the complexity they created. But the really big shift, the seminal change, came around 2020, marked by the release of the Healthy People 2030 framework.
Ah, the latest iteration.
Yes, and it completely restructured the national public health agenda on this topic. It basically said, hold on, we need to rethink who's responsible here.
And this is where the conversation splits, right? It moves from just one definition to a dual framework.
Exactly. Health literacy is now formally recognized as two interconnected concepts. First, we still have personal health literacy that still focuses on the individual's ability.
Okay.
But second, and this is the real game changer, we now have organizational health literacy, and this focuses squarely on the organization's responsibility, their legal and, frankly, moral responsibility to make things understandable.
Let's break down those definitions because the specific words matter a lot. The new personal definition. It shifts from that passive idea of capacity to the individual's ability to find, understand, and use information. That word use seems critical.
It's absolutely critical. The shift to ability to use demands active application. It's not just asking, can you read the words on the page? It's asking, can you take that information and actually do something with it?
Give yourself an injection correctly.
Yes. Or schedule the right follow-up appointment, or manage a complex dietary plan based on the instructions. It's about successful navigation in real life.
There's also that other subtle change. The old definition aimed for patients to make appropriate health decisions.
What's the new goal?
The new goal is for the patient to make well-informed decisions.
Appropriate versus well-informed. That feels important.
It's a profound nod to patient autonomy, to shared decision-making. The system's job isn't to decide what's appropriate for you. Its job is to fully inform you, options, risks, benefits, so you can make the choice that aligns with your values and goals.
Okay, that makes sense. And then the organizational definition. This is where that equity mandate really comes in strong, right? The degree to which organizations equitably enable individuals to find, understand, and use information.
That phrase, equitably enable, that's a policy breakthrough. It's huge. It formally acknowledges that the healthcare environment itself, how complex it is, how clearly it communicates, is just as crucial as the patient's individual skills.
So limited health literacy isn't just a patient problem anymore. No. It's reframed as a systemic quality and safety issue, a matter of justice even. If the organization fails to simplify its forms, its jargon, its websites, its waiting rooms, then it's the organization that has failed its mission of care, not the patient who failed to understand.
Wow. Okay, so if an organization is actually living up to this new standard, they have to recognize that health literacy is way more than just reading ability.
Absolutely.
It's a whole collection, a constellation of skills, as the research puts it.
That's a great way to put it. It's multifaceted. Obviously, it includes print literacy, reading brochures, forms, and oral literacy, listening to instructions, asking questions, but it goes much deeper.
Into cognitive skills.
Yes. It requires analytical skills. It requires complex decision-making capabilities, especially when you're dealing with risk and probability, which is constant in healthcare.
And what's the one skill within that constellation that trips up almost everyone, even highly educated people?
Oh, without a doubt, it's numeracy, health numeracy, the ability to understand and use numbers in a health context.
Give me some examples.
It's pervasive. Interpreting lab results, understanding what that cholesterol percentage actually means, calculating the correct dosage of your child's fever medicine based on their weight, comparing complex financial stuff like deductibles and copays between different insurance plans.
Yeah, that last one.
Yeah.
Comparing plans, that can feel impossible.
It often is. And it's not just simple math, it's handling probability, understanding risk. Like grasping the difference between, say, a 1% chance of a rare side effect versus a 1 in 100 risk accumulating over 5 years. That kind of comparison. It scrambles most people's brains, especially under stress.
Even mine, probably, if I'm sitting there worried about a diagnosis.
Precisely. Humans are notoriously bad at probabilistic reasoning, just generally, and healthcare is absolutely full of it. When a doctor says this treatment reduces your risk of recurrence by 50%, what does the patient hear?
They might hear, oh, I have a 50% chance of being cured.
Exactly, which are two very, very different things. That failure to clearly communicate probabilistic risk, that's major health literacy gap, often on the provider side.
Okay, and there's one more level you mentioned, critical health literacy. What's that about?
Yes, this is especially crucial in today's digital world with information overload. Critical health literacy is the ability to not just read the information, but to critically evaluate it.
So figuring out if what you're reading online is actually trustworthy.
Exactly. Recognizing potential bias. Is this legitimate science or is it sponsored content? Is this a pharma marketing claim disguised as education? It's about being able to sift through the noise, apply credible information, and use it to advocate for yourself and take more control over your health decisions. It's the highest level skill, really.
Okay, so the definitions have shifted dramatically, placing responsibility on the system. But let's ground this conversation back in the numbers. How widespread is this problem? Who's most affected?
The statistics are, well, they're pretty eye-opening, and they really underscore why this is a national crisis. Data from the National Assessment of Adult Literacy, the NAAL, it's a bit dated now, but still the benchmark, revealed that only a mere 12% of U.S. adults possess proficient health literacy skills.
Only 12%. So you're saying nearly 9 out of 10 adults struggle with some core aspect of finding, understanding, or using complex health information.
That's what the data suggests.
Yeah.
And we can quantify the depth of that struggle even more. Over 1/3 of the adult population, that's somewhere between 77 and 90 million people, were found to have only basic or below basic health literacy.
Wow. What does basic or below basic mean in practice?
It means struggling with tasks that many people, especially system designers, assume are simple, like correctly following the directions on a standard over-the-counter drug label, or understanding a routine childhood immunization schedule chart, or reading a simple appointment slip.
That 9 out of 10 figure is actually terrifying when you think about how often we're all navigating medical forms, instructions, prescriptions.
It is.
And while this clearly impacts almost everyone at some point because we all face stress and complex infos, the burden isn't shared equally, is it? This is fundamentally an equity issue.
Absolutely. The research consistently and depressingly shows that limited health literacy is significantly higher among populations already facing systemic barriers.
Such as?
Older adults, particularly those over 65, specific racial and ethnic minority groups, Latino, Black, American Indian, Alaska Native populations consistently show lower average scores. Individuals with lower income, lower levels of formal education, and people with limited English proficiency.
So the existing structural barriers in society are basically amplified by poor health communication from the system.
Exactly, compounded. And it's crucial to remember, as you said, that health literacy is situational. Even highly literate people can struggle.
Right. Can you give an example of that?
Sure. Think about walking into an emergency room right after a car accident. You're in pain, you're scared, maybe disoriented, or sitting in an oncologist's office and hearing a serious diagnosis for the first time.
Your brain just kind of shuts down.
Your cognitive capacity is immediately compromised by stress, by pain, by fear. Even if you hold a PhD, if the doctor starts rattling off complex medical jargon at high speed, your functional health literacy in that moment plummets.
Which really makes the case for what they call the universal precautions approach, doesn't it?
It absolutely does. Design the system, the communication, the forms for clarity under stress. Assume everyone might struggle at some point.
Yeah.
If you design for the lowest common denominator of understanding and the highest stress level, everyone benefits.
So when these communication failures happen, when the system isn't clear and the patient can't navigate it, what are the downstream effects? Paint a picture of the clinical consequences.
The clinical outcomes linked to limited HL are consistently negative and really well documented. We see demonstrably higher rates of hospitalization and, crucially, much higher rates of repeat use of emergency departments for conditions that really should have been managed preventatively or in primary care.
So people end up in the ER because they couldn't manage their condition at home.
Often, yes, or didn't understand the warning signs they should have called their doctor about earlier. These patients also show lower utilization of essential preventive services, things like flu shots, mammograms, colon cancer screenings. Problems get caught later when they're harder and more expensive to treat.
And what about medication adherence? That's a huge challenge in healthcare generally.
Medication adherence suffers dramatically. Limited HL is strongly associated with a higher incidence of medication errors. People have difficulty interpreting labels, they misunderstand dosage instructions, or when they're supposed to take things, especially if the regimen changes.
Which logically leads to poor management of chronic diseases.
Definitely. Poor management of things like diabetes, hypertension, heart disease, which in turn leads to greater long-term complications, reduced quality of life.
And the ultimate consequence, the bottom line.
The research is stark. Limited health literacy is independently associated with poorer overall self-reported health status, and most critically, multiple studies have now confirmed a direct link to higher mortality rates.
Wow, so this isn't just about inconvenience or extra cost. It's literally a life or death issue.
It truly is, which demands that organizations take it seriously as a core safety imperative.
Okay, which brings us right back to that staggering economic number. Let's dissect that $349 billion figure again. How does that cost actually get generated by the system? What drives it?
That enormous figure is essentially the cumulative price tag of inefficiency and failure. It's driven by the costs related to preventable hospital admissions. Think about the patient with diabetes who didn't understand how to adjust their insulin or monitor their blood sugar and ends up in the ICU with ketoacidosis.
Right, avoidable crises.
Exactly. It includes the huge cost of hospital readmissions, patients discharged without fully grasping their post-care instructions, maybe about wound care or new medications, and they bounce right back to the hospital a week later.
More ER visits, more hospital days.
Yes, it covers inefficient resource use, like redundant testing, because information wasn't shared or understood. It's the cost of treating complications that were entirely avoidable if the initial communication had been clear and understood and confirmed. If the system were designed for clarity, a significant chunk of that $349 billion would simply vanish.
So connecting this back to the social context, this is where that distinction between the two types of health literacy becomes really important, right? Personal versus organizational.
Exactly. The new HHS framework helps clarify this. We now classify personal health literacy, that's the individual's characteristic, their skill level, as a social risk. It puts a person at higher risk for poor health because of their individual skills.
Okay, a risk factor.
But organizational health literacy, the clarity, the navigability, the fairness of the system itself, that's classified as a social determinant of health, SDOH.
Okay, hold on. So the system's failure to communicate clearly is now considered a fundamental determinant of health outcomes, just like things we usually think of, like access to clean water or safe housing or healthy food.
Precisely. That's the power of this reframing. If we apply that SDOH lens, you can see how it perpetuates a really vicious cycle.
Explain that cycle.
Okay, so social disadvantage like low income, unstable housing, maybe lower educational attainment often leads to or correlates with limited personal health literacy skills. Then that limited personal HL acts as a multiplier. It translates that social disadvantage into concrete poor health outcomes like uncontrolled hypertension because the patient couldn't navigate the medication refills or understand the dietary advice.
And then the poor health makes the social situation worse.
Exactly. The resulting poor health then reinforces the initial social and economic challenges. Maybe job instability because of chronic illness and frequent doctor visits, difficulty affording medications. It locks people into a cycle of disadvantage.
Can you give a concrete example of organizational health literacy acting as an SDOH, where the system is the barrier?
Absolutely. Imagine a low-income patient who relies on public transportation. Maybe they also have low digital literacy skills, not comfortable with computers or smartphones. Their primary care clinic decides to shift all its appointment scheduling, prescription refills, and lab result delivery exclusively to a complex online patient portal. And maybe that portal requires two-factor authentication, only works well on a high-end smartphone, and is filled with medical jargon. That technological barrier, which the organization itself created and imposed, is an SDOH in action. It effectively prevents that patient from accessing necessary care, regardless of their ability to read basic text. The organization's choice created the barrier.
Wow, okay. That makes the investment rationale crystal clear. Improving organizational health literacy isn't just about being nice or doing the right thing morally.
It's fiscally responsible. It's a high-yield investment for the system because vulnerable populations, those most affected by limited HL, disproportionately rely on publicly funded programs like Medicare and Medicaid.
A massive slice of that $349 billion in excess costs is actually borne by the taxpayer.
That's right. Therefore, interventions designed to improve organizational health literacy, making the system clearer, simpler, easier to navigate, are actually fiscally prudent strategies. They can reduce public expenditure, make the system more sustainable, and not incidentally create a more equitable system for everyone.
Okay, so the evidence is overwhelming. We've got the clinical risks, the equity mandate, and this enormous cost driving the need for change. This led the federal government to establish a pretty robust, coordinated national roadmap. Who are the key players inside HHS driving this?
Yeah, the national strategy is actually quite coordinated, which is good to see. At the very top, you have HHS, the Department of Health and Human Services itself. They set the overarching vision through things like the National Action Plan to Improve Health Literacy and, crucially, the Healthy People 2030 objectives we discussed. Those objectives contain the new definitions that mandate equity and organizational accountability. So HHS provides the big picture what? The strategic direction.
Okay, the what? Then you've got the key agencies under HHS that are responsible for the practical how, the implementation.
Exactly. First, you have the CDC, the Centers for Disease Control and Prevention. They really act as the hub for practical public health application.
What do they provide?
They give public health professionals concrete tools, evidence-based communication strategies, practical guides on using plain language, training programs to build skills and clear communication across the entire workforce. The CDC basically gives you the communication cheat sheet, the practical guides.
Got it. And then the agency that generates the evidence, making sure these tools actually work. That's AHRQ.
Yes, AHRQ, the Agency for Healthcare Research and Quality, they are absolutely vital because they generate the evidence and the tools. AHRQ funds research on which interventions are most effective. And importantly, they're responsible for developing the incredibly influential Health Literacy Universal Precautions Toolkit.
What is that toolkit exactly?
Think of it as the operational manual. It translates abstract academic research findings into concrete, step-by-step clinical quality improvement strategies, things that hospitals and clinics can pick up and implement right away to improve clarity.
Okay. And finally, the engine driving the basic science. That's the NIH.
Right. The National Institutes of Health. They drive the foundational scientific understanding through initiatives like their Clear Communication Program. They expand the research base that underpins all these policies and practices, making sure the strategies we use are grounded in the best understanding of how people actually learn, process information, and make decisions, especially under stress.
So all this coordination feeds into the National Action Plan, which you mentioned, and it's grounded in some core principles.
Two core principles, really. First, that everyone has the right to the health information they need to make informed decisions. And second, that health services themselves must be delivered in ways that are easy to understand and that improve health, longevity, and quality of life.
The plan has broad goals, accessible information, systemic changes, education integration, local efforts.
Yeah.
But as you said earlier, high-level mandates aren't always enough. There's often a big gap.
A huge implementation gap, yeah, between the federal mandate saying do this and what actually happens on the floor of a busy hospital or a community clinic. Policy is one thing, practice is another.
And that gap is precisely why the National Academy of Medicine, the NAM, stepped in and created that detailed organizational framework.
Exactly. They developed the 10 attributes of a health-literate healthcare organization. This framework is the critical roadmap. It's designed specifically to bridge that gap, translating those abstract federal goals into very concrete, measurable institutional changes. It forces organizations to look inward at their own practices.
Let's dig into some powerful examples from those 10 attributes. Where does it start? Top down.
Absolutely. Attribute 1 is leadership. It states that health literacy must be integral to the organization's mission, its structure, its quality improvement efforts, its strategic plan.
What does that mean in practice?
It means the CEO, the senior leadership, the board, they have to actively champion clarity. It has to be communicated as a core organizational value, not just a side project tucked away in the patient education department. It needs to be built into performance metrics, resource allocation decisions. If the leadership doesn't visibly buy in and drive it, it just won't happen systemically.
And it's not just about doctors and nurses, right? This involves everyone in the building.
That's attribute 3, workforce. This attribute calls for mandatory ongoing training for all staff. And they mean all staff: clinical, administrative, environmental services, billing, security, volunteers, everyone who interacts with patients or their families.
Training on what specifically?
On clear communication techniques, especially things like using plain language, which we'll talk more about, and the teach-back method to confirm understanding. The logic is simple. If the person answering the phone can't clearly explain appointment logistics, or the person checking the patient in uses confusing jargon, or the billing department sends out incomprehensible statements, that's an organizational health literacy failure right there.
Okay, hold on. Mandatory ongoing training for all staff, from surgeons to the cafeteria workers who might give directions. That sounds hugely expensive and incredibly time-consuming.
It is.
Are the sources showing that hospitals are genuinely buying into this level of commitment? Or is this still largely aspirational?
That's the million-dollar question, isn't it? And it's the core challenge discussed in the research on implementation science. The sources absolutely recognize the significant upfront investment in developing training materials, in staff time away from other duties. It's not trivial.
So how do they justify it?
They argue, and the organizations that have successfully implemented this argue, that the cost is more than offset by the return on investment we talked about earlier. Fewer costly readmissions, fewer errors, fewer angry phone calls to the billing department trying to decipher a statement, lower malpractice risk because of better informed consent.
So the argument is, it pays for itself in the long run.
Exactly. The organizations that truly embed this see it as a fundamental quality improvement initiative that ultimately saves money and improves outcomes, not just an added expense or regulatory burden. But yes, getting universal buy-in for that level of training remains a major hurdle for many institutions.
What about bringing the patient voice into this? How are patients involved in making things clearer?
That's attribute 4, audience engagement. This is crucial. It involves actively engaging patients and their families in reviewing, testing, and even co-designing materials, services, digital tools, and physical spaces before they're finalized and rolled out.
How does that work practically?
Often through formal mechanisms like patient and family advisory councils or PFACs. These groups bring diverse patient perspectives directly into the design process. It ensures that the materials and processes aren't just clear to the clinicians who wrote them, but are actually tested and validated by the people who need to use them under real-world conditions.
Makes sense. And what about that part of healthcare everyone dreads, the bills, the insurance, the costs? Is that covered?
Oh, yes. That falls squarely under attribute 10. Policy and procedure. The organization has a responsibility to communicate clearly and accessibly about coverage, the billing process, and estimated costs.
So, no more incomprehensible explanation of benefits.
Well, that's the goal. Billing statements, insurance explanations, financial assistance applications, cost estimates, they all need to be drafted using plain language principles. The aim is to make them easy for patients to understand, which can help mitigate what researchers call financial toxicity.
Financial toxicity.
Yeah, the phenomenon where patients avoid necessary care or suffer immense stress simply because the cost complexity and unpredictability is too high and too opaque. Clear financial communication is part of health literacy.
Okay, listening to all this, implementing these 10 attributes system-wide sounds incredibly complex. It requires expertise in communication, education, quality improvement. This isn't something an already overburdened doctor or nurse manager can just tack onto their existing duties, right?
You've hit on a key point, exactly right. The sheer complexity of doing this properly, systemically, is driving the professionalization of the field. We're seeing the emergence of dedicated roles,
Like what?
like the health literacy specialist or the health literacy officer. This role requires specific expertise in communication science, adult learning principles, usability testing, quality improvement methodology, change management. It's a specialized skill set.
So it's becoming a real profession.
Yes, the availability now of formal credentials like the Institute for Healthcare Advancement's Health Literacy Specialist Certificate confirms this. It's evolving into a dedicated professional leadership role, often sitting alongside or maybe even reporting to the Chief Quality Officer or Chief Experience Officer in a healthcare system. It needs dedicated leadership to make it stick.
All right, we've established the systemic mandate, the why, and we've seen the organizational roadmap with the 10 attributes. Now let's focus on the how, the specific evidence-based tools that organizations use to actually do this work. The sources highlight two major complementary strategies, starting with the absolute cornerstone, plain language.
Plain language is fundamental. It's the bedrock. And the definition is important. It's not just about using simple words. It's communication that your audience can understand the first time they read or hear it.
The first time.
Yes. So they can find what they need, understand what they find, and crucially use that information to meet their needs. The key is clarity and efficiency. It is absolutely not about dumbing down complex medical concepts. It's about expressing them clearly.
And this isn't just a nice to have. There's actually a federal mandate for government agencies, right?
That's right. The Plain Writing Act of 2010 requires federal agencies to use clear communication that the public can understand and use. That law really helps set the standard and expectation for other sectors, including healthcare.
So how does it work in practice? What are the specific techniques?
It starts with word choice, using common, everyday words instead of jargon or technical terms whenever possible.
Like saying high blood pressure instead of hypertension.
Exactly. Or pain reliever instead of analgesic. Or maybe even using tummy instead of abdomen when speaking to a child or in certain contexts. It's about meeting the reader or listener where they are linguistically.
Okay, word choice is one piece. What about the structure? Because a lot of health forms are just these dense walls of text.
Right. Structure is vital for reducing cognitive load and making information easier to scan and digest. Key techniques include writing in the active voice.
Why active voice?
It's generally more direct, uses fewer words, and is easier to process. The nurse will give you the shot is clearer and more direct than the shot will be given to you by the nurse.
Makes sense.
What else?
Using personal pronouns like you and we helps create a more engaging, direct, and less intimidating tone. Instead of patients should, try you should. And the length, sentence length, paragraph length. That seems like a big hurdle for people used to writing formally.
It is a big hurdle, but it's critical. The guidance is to keep sentences and paragraphs short and focused on one main point. Aiming for an average sentence length of maybe 20 words or fewer is a good target.
20 words, that's concise.
It forces clarity. And then, organizing the information for scalability is key, using clear, informative headings. Using bullet points or numbered lists instead of long narrative paragraphs. White space is your friend. It allows the reader to quickly find the specific piece of information they need right now.
So plain language is all about delivering a clear message, making the input clear. But you mentioned earlier, people forget a ton of what they're told in a medical setting. Up to 80%, you said.
That's the research finding, yes. And nearly half of what they do remember might be incorrect.
So just making the initial message clear isn't enough. How do we ensure that clear message was actually received, understood, and retained accurately?
That is the critical safety check. And that's where the second major tool comes in. The teach-back method. Teach-back is the organizational mechanism, the process to confirm understanding. It closes that communication loop between the provider and the patient. It's simple in concept, incredibly powerful in practice, and it fundamentally shifts the accountability for clear communication onto the provider. It links directly back to Attribute 6 of the Health-Literate Organization Ensuring Understanding.
And the psychological key, as you mentioned, is that it's framed as a test of how well the provider explained, not a test of the patient's knowledge or intelligence.
That is absolutely the psychological key. It removes the shame factor. When it's introduced properly, the patient doesn't feel like they're being quizzed or put on the spot. They feel like the provider cares enough to make sure they did a good job explaining something complex.
So how do you do it properly? There's a framework for this, right? The 5 T's.
Yes, the 5 T's of Teachback is a helpful framework for implementing it effectively.
Walk us through those 5 T's. Let's imagine a provider talking to a patient about a new medication. How would they use this?
Okay. 1. Triage. First, before you even start explaining, the provider needs to triage the information. Focus only on the 1 to 3 most important need-to-know pieces of information for this specific interaction. Don't try to teach back 15 different things.
So for a new blood pressure medicine,
Maybe it's what the medicine is called and the dose, when exactly to take it, and maybe one key warning sign that means they should call the doctor right away. Just those 3. Keep it focused.
okay, triage. What's next?
2. Tools. Use visual aids, written materials, or demonstrations as tools to supplement the verbal explanation. Show them a picture of the pill. Circle the dose on the handout. Use a calendar to show when to take it. Don't just rely on talking. People remember visuals better.
Got it. Tools, number 3.
3. Take responsibility. This is where that crucial non-shaming language comes in. The provider introduces the teachback by explicitly taking responsibility for the clarity of their explanation.
How would they phrase that?
They might say something like, I know this is a lot of new information, and I want to make sure I did a good job explaining everything clearly. Could you tell me in your own words, what are the 2 most important things you need to remember about this new medicine when you get home? Or, just so I know I was clear, can you show me how you're going to use this inhaler?
Okay, so it's, I want to be sure I was clear, not do you understand?
Exactly. Never do you understand. That just invites a yes, even if the patient is totally lost.
Okay, take responsibility. What's the 4th T?
4. Tell me. Ask open-ended questions that prompts the patient to tell you in their own words or show you what they understand. Avoid those closed yes-no questions.
So instead of did you get that?
Ask, can you tell me what you're going to do if you experience side effect? Or show me on this schedule when you plan to take your pill tomorrow morning. Get them to articulate or demonstrate.
Makes sense. And the last T, what if they don't get it right?
5. Try again. If the patient's teachback reveals a misunderstanding, maybe they describe taking the medicine twice a day when it should be once, or they demonstrate using the inhaler incorrectly, the provider must take responsibility again. They say something like, okay, thanks for showing me. Actually, let me explain that part again, maybe using this picture this time. Then they re-explain the material using a different approach, maybe slower, maybe using the visual tool more, maybe breaking it down further, and then
You check again.
you check for understanding again using teachback. You cycle back through, try again until comprehension is confirmed. The responsibility remains with the provider to find a way to explain clearly.
Wow, that dual approach, plain language providing the clarity of delivery and teachback ensuring the accuracy of reception, feels like a really robust system for patient safety when used together.
They are essential complements, yes.
And it's comforting to know these aren't just, theoretical ideas in a toolkit. They are being successfully applied in the real world.
Absolutely. We see great examples in large-scale public health campaigns run by the CDC. Think about the Tips from Former Smokers campaign.
Yeah, those are powerful ads.
Incredibly powerful. They use plain language, relatable stories, strong emotions, and they've been proven to drive behavioral change, getting people to quit smoking. That's health literacy in action on a mass scale.
Any other examples?
The CDC's Hear Her campaign is another good one. It focuses on urgent maternal warning signs during and after pregnancy. It uses very clear, direct, actionable language to empower women and their support networks to recognize potentially life-threatening symptoms and speak up confidently to their providers.
So big national campaigns work. What about at the community level? Because healthcare doesn't just happen in the clinic or through TV ads.
Right. We also see real success with grassroots initiatives that meet people where they are. Acknowledging the community context is key.
Like what kind of initiatives?
Well, some communities have had success leveraging public libraries as trusted health information hubs, especially in areas where healthcare access might be limited. The Oklahoma Health Equity Campaign, for instance, partnered successfully with libraries for community health education workshops.
Libraries as health hubs. Interesting.
Yeah. And local nonprofits play a huge role, too. Organizations like Health Confianza down in San Antonio, for example, they provide culturally relevant health programs and also deliver targeted health literacy training for local healthcare workers, helping bridge cultural and linguistic gaps. The key is localizing the content and delivering it through trusted messengers within the community itself.
Okay, we've covered the system shift, the cost, the roadmap, the core tools like plain language and TeachPack. But now we have to pivot to where so much health information lives today, the digital space. This introduces a whole new layer of complexity and a new essential skill set, digital health literacy.
Or e-health literacy, yeah.
Hmm.
It's unavoidable. The digital transformation in healthcare holds immense promise. Instant access to your records, personalized care pathways, telehealth convenience.
Huge potential benefits.
Absolutely. But it simultaneously creates a really significant risk of widening the existing health disparities we've already talked about if we don't handle this transition with extreme care and intention.
So first, let's define digital health literacy. What is it exactly?
It's rapidly becoming a fundamental requirement for navigating modern life, let alone healthcare. We define it broadly as the ability to seek, find, understand, and critically appraise health information from electronic sources, websites, portals, apps, wearables, and then successfully apply that knowledge or information to address a health problem or make a health decision.
Seek, find, understand, appraise, and apply. That appraise part seems extra important online.
Critically important given the amount of misinformation out there. And it's a complex hybrid skill set. It's not just one thing.
Meaning it requires a blend of different competencies.
Exactly. The research suggests it requires at least 4 overlapping skill sets. 1, you still need traditional personal health literacy, understanding the basic health concepts themselves. 2, you need computer digital literacy, the technical skills. Can you operate a smartphone, a tablet, a computer? Can you troubleshoot a lost connection? Can you navigate software interfaces? 3, you need information literacy. Can you use search engines effectively? Do you know how to use keywords? Can you navigate complex websites or patient portals to find the specific piece of information you need? 4, and as you highlighted, absolutely essential today is media literacy, that critical skill of evaluating online sources. Is this information credible? Who wrote it? What's their agenda? Can you distinguish evidence-based information from sponsored content or outright misinformation, maybe even deepfakes?
Wow, that's a lot to expect from everyone, especially when they might be sick or stressed.
It is a huge expectation. And the usage data shows this digital shift is happening incredibly fast, whether we're ready or not. We've seen patient portal access surge dramatically in recent years.
People using apps on their phones to get lab results message their doctor.
Exactly. Research shows something like half of all patient portal users are now accessing it primarily via a smartphone app. So that rapid adoption is the promise, right? The convenience, the self-management tools from wearables, the potential for a stronger patient-provider connection through secure messaging, direct access to your own records.
That's the upside. What's the peril? You mentioned the risk of widening disparities.
That is the critical peril, the digital divide. The gap in access, skills, and confidence between different population groups threatens to significantly widen the health disparities that already exist. If we're not careful, the default trajectory of digital healthcare is actually towards greater inequity. We have to actively engineer against that.
What are the key barriers creating this divide, especially for the most vulnerable populations?
There are several major ones. First is simply infrastructure. Lack of reliable, affordable broadband internet access. This is a massive barrier, especially in rural areas and low-income urban neighborhoods. Estimates suggest around 19 million Americans still lack access.
19 million. Can't participate if you can't connect.
Exactly. Second is hardware. The cost of devices. Not everyone can afford a reliable smartphone, tablet, or computer, or the data plan to go with it. Third is skills and confidence. Many people, particularly older adults or those with lower educational attainment, have limited digital literacy skills or lack confidence in using technology, making them hesitant or prone to errors or security risks.
So if essential healthcare functions like scheduling appointments, requesting prescription refills, getting test results, even communicating with your doctor migrate entirely online,
then those people without reliable access or the necessary devices or the skills and confidence to use them are effectively left behind. They risk being shut out of accessing care or managing their health effectively through the channels the system now relies on.
it creates an immediate two-tiered system. Those who can navigate the digital world get the benefits, and those who can't face new, potentially insurmountable barriers.
Precisely. The dynamic is so powerful, so pervasive that some researchers have started calling digital literacy a super social determinant of health.
A super SDOH. Why super?
Because in today's world, digital access and skills are increasingly becoming the gateway required to access virtually every other resource or affinity, education, employment, social services, banking, civic engagement, and Critically, healthcare. If you lack digital literacy, you're at a disadvantage across the board.
And applying this back to organizational responsibility, a poorly designed, jargon-filled, hard-to-navigate patient portal isn't just annoying.
It's a direct failure of organizational health literacy in the 21st century. Full stop. The organization has a responsibility to make its digital front door as clear and accessible as its physical front door.
So the organization needs to adopt, essentially, digital universal precautions, applying those same principles of clarity and ease of use to the digital environment. How does that work?
Yes, they have to intentionally apply health literacy and usability principles to the design of all their patient-facing digital tools, websites, portals, apps. The foundational strategy, just like with print materials, is know your audience. Meaning you must conduct usability testing with diverse groups of actual users early and often in the design process. Include older adults. Include people with known limited digital skills. Include people whose primary access is via a basic smartphone. Co-design the system with them. Don't just design for them based on assumptions.
And the content itself, the text on the screen, the instructions, the notifications, needs to follow plain language rules.
Absolutely critical. All content, the user interface text, the error messages, the appointment reminders, any educational materials embedded within the tool should be written in clear, simple, actionable, plain language. Often targeting a 6th to 8th grade reading level is a good benchmark.
Recognizing how people access this.
Organizations absolutely must prioritize a mobile-first design approach. Recognize that for a large and growing segment of the population, especially lower-income individuals, the smartphone is their primary, maybe only, point of internet access. Complex menus and features designed for a large desktop monitor simply won't work well or be accessible on a small mobile screen. Design for mobile first, then adapt for larger screens.
How do you apply something like the teach back principle in a digital environment? You can't really have a conversation with an app.
Not in the same way, no. But you can apply the principle of confirming understanding. You integrate simple confirmation steps, clear summaries, or check your understanding questions after a user completes a complex or high-stakes task digitally.
Like booking surgery.
Exactly. Or confirming a change to their medication list, or scheduling multiple appointments, or entering sensitive personal health data. After they submit, the portal or app might display a clear summary. Okay. You successfully scheduled your surgery follow-up for Tuesday, October 15th at 10:00 a.m. with Dr. Smith. We will send a text reminder to phone number 2 days before. Does this look correct? It helps reduce user error and provides reassurance that the intended action was received correctly.
Okay, so better design helps, but technology alone clearly isn't going to solve the digital divide for everyone. The research points towards needing human support models as well.
Definitely. We absolutely need high-touch human intervention to bridge the technical and skills gaps, especially for those most at risk of being left behind. 2 models are showing particular promise in the research.
What are they?
First, the concept of digital health navigators embedded within healthcare settings. These are specially trained staff, maybe community health workers, volunteers, or clinic staff, who provide dedicated one-on-one assistance to patients right there in the waiting room or clinic.
Helping with what?
Helping them enroll in the patient portal, learn how to use its basic features, troubleshoot login problems, prepare for a telehealth visit, download and use relevant health apps. They provide immediate, on-the-spot technical support and coaching.
Okay, that makes sense for help in the clinic. What about support at home, especially for, say, older adults who might be less mobile?
That's where the second model comes in, which is more resource-intensive but potentially very high impact. It's sometimes described colloquially as the Geek Squad for Health.
Like the tech support service.
Kind of, yeah, but focused specifically on health technology access. This model provides personalized, often in-home, technical assistance, especially targeted towards older adults or people with disabilities. They might help set up a tablet or smartphone, establish a reliable internet connection, install and configure necessary health apps or telehealth software, and provide patient-tailored training on how to use these tools confidently.
So it's addressing both the technical barriers and the skills and confidence barriers right in the person's home environment.
Exactly. It's high touch, addresses social needs alongside technical ones, and builds trust. It's a crucial piece for ensuring the digital transformation doesn't leave our most vulnerable populations behind.
Okay, we've covered a lot of ground. We know the link between limited health literacy and poor outcomes is really robust. The evidence for foundational interventions like plain language and teach back seems strong. But if the problem and some core solutions are so well defined, where does the research need to go next? What are the key gaps?
That's a great question. I think the biggest gaps now concern scale, sustainability, and system-level accountability. While we have excellent frameworks like the 10 attributes, the research base evaluating the real world impact of implementing these organizational level interventions across diverse healthcare settings is still relatively scarce.
So we think implementing all 10 attributes is the right thing to do, but we need more hard data proving its impact across the board.
Exactly. We need more rigorous studies. And critically, we need better standardized measurement tools to assess organizational health literacy effectively. We need to be able to determine which specific systemic changes, like mandatory staff training versus redesigning billing formats versus investing in digital navigators, yield the greatest clinical improvements and financial returns. We need to pinpoint the highest impact levers for change within an organization.
Which leads directly to what you flagged as the most crucial evolution in the research agenda right now, that explicit pivot towards economics, connecting health literacy directly to dollars and cents.
This is absolutely paramount for driving widespread, sustainable adoption, especially in the U.S. healthcare system. Let's be blunt. Lasting change in hospitals and health systems often requires a compelling business case.
Sad but true.
It is. So the new research agenda must focus heavily on measuring return on investment, ROI. Researchers are now actively prioritizing studies that link health literacy interventions directly to the metrics that matter most to C-suite leadership.
Such as
Reduced hospital readmission rates for specific conditions like heart failure or COPD, shorter average length of stay, lower emergency department utilization for problems that could have been managed in primary care, improved patient satisfaction scores, which can affect reimbursement, and ultimately, demonstrating positive impacts on the organization's overall financial performance, maybe through improved efficiency or reduced malpractice claims.
So the goal is hard, auditable evidence that says if you invest $1 in improving organizational health literacy, you will get $6 back in cost savings or improved revenue.
That's the holy grail, essentially. That kind of evidence is what will likely motivate large-scale, sustained investment across the industry, moving it from a nice-to-do compliance activity to a core strategic imperative.
Looking even further ahead, emerging technology, particularly artificial intelligence, seems poised to fundamentally change how we all receive and process health information. What's the potential there and what are the risks?
AI and machine learning. They offer some incredible potential, no doubt. Imagine, for instance, hyper-personalized communication tools. A chatbot that can instantly translate complex lab results into the specific plain language level and format most appropriate for your individual literacy level, your preferred language, maybe even your cultural background.
Or targeted reminders and support tailored precisely to your medication schedule and health goal.
Exactly. The potential for truly individualized adaptive communication and support is enormous.
But there's always a but with AI, isn't there? The sources flag a major risk here too.
They certainly do. The huge challenge with AI in this space is the very real risk of inadvertently perpetuating or even worsening health disparities through biased algorithms.
How would that happen?
Well, if the vast data sets used to train these AI communication models are drawn disproportionately from populations who are already high literacy, high access, digitally savvy, and predominantly English speaking,
Then the AI learns to communicate best with those people.
precisely. The resulting AI system, the chatbot or personalized tool, might then fail to communicate effectively with or even actively misinform patients from marginalized groups whose language patterns, cultural contexts, or literacy levels weren't well represented in the training data. This could unintentionally deepen structural inequities, completely defeating the purpose of using AI for health literacy improvement. Algorithmic bias is a massive concern here.
Okay. And compounding all this is the fact that the complexity of the health information itself just keeps accelerating, right?
Yeah.
We're talking genomic data, incredibly complex visualizations in patient portals, predictive risk scores.
Yes, that's the meta challenge looming over all of this. The sheer volume and complexity of health information patients are expected to engage with is exploding. The concern is that the gap between the healthcare system's increasing informational demands the level of digital skill, numeracy, scientific literacy required, and the actual skills and capacities of the general public may be widening faster than our current health literacy interventions can possibly compensate.
We're falling further behind.
Potentially, yes. The treadmill is speeding up. This increasing complexity is actually leading some researchers and policymakers to propose moving conceptually beyond just health literacy, as we currently define it,
Towards what?
towards a broader, maybe more ambitious concept, sometimes termed health information fluency.
Health information fluency. What does that entail?
It suggests a goal of more universal, effective, and adaptive use of health information within a constantly changing, dynamic, and incredibly complex system. It implies not just basic understanding, but a deeper capability to navigate, integrate, and apply diverse streams of health data effectively throughout one's life. It's a higher bar, perhaps reflecting the reality of the future information environment.
Okay, so bring this all together. Based on everything we've discussed, the systemic shift, the costs, the tools, the digital challenges, the future trends, what are the ultimate actionable recommendations? What should the key stakeholders be doing now?
But the sources converge on several key recommendations.
They hold the power of the purse strings and regulations. They need to seriously explore integrating meaningful measures of organizational health literacy into federal quality reporting programs like those used by Medicare. And crucially, link those measures to value-based payment models.
So create real financial incentives and penalties.
Exactly. If there's no reward or penalty tied to clarity and accessibility, the motivation for busy health systems to prioritize it will remain limited. Policy needs to create strong financial incentives for change.
Okay. What about for healthcare organizations themselves? Hospitals, clinics?
They need to move beyond lip service, formally adopt and actively implement frameworks like the 10 attributes, commit to that mandatory ongoing effective training for all staff, and significantly invest in and scale up those digital inclusion programs, like providing digital navigators and robust patient portal support. Make it a core operational priority, led from the top.
And for the researchers, where should their focus be?
As we discussed, the priority must be on implementation science, figuring out how to best implement these strategies in complex, real-world settings, and on conducting those rigorous ROI studies that directly connect health literacy investments to tangible cost savings and quality improvements. Provide the business case.
Finally, what about educators, both for health professionals and for the general public?
Education is critical for the long game. Health literacy principles, clear communication, patient-centeredness, checking understanding, cultural humility must be integrated as a core competency throughout all health professions training curricula. Doctors, nurses, pharmacists, therapists, everyone needs these skills from day one.
And for the rest of us, K-12 education.
Yes, we also need to think about systematically integrating age-appropriate health literacy concepts and skills into K-12 education. Build that foundational knowledge about health, navigating the system, evaluating information, starting early, create a more health-literate population over the entire lifespan. Hashtag tag outro.
Wow. This has been a really necessary and I think profound deep dive. If there's one core takeaway for you, the listener, it seems absolutely clear. Health literacy is not just your problem to solve alone. It's a systemic quality and equity issue. An issue that costs our economy a staggering $349 billion every year. And the solution lies not primarily in fixing the patient, but in healthcare organizations actively fulfilling their fundamental duty to equitably enable understanding. It is their responsibility to engineer clarity into the system.
Exactly. And if you only remember two practical tools from our entire discussion today, make it these. Plain language for ensuring clarity in communication delivery.
Making the message clear up front.
Yes. And the teach-back method for confirming the accuracy of reception.
Checking that the clear message actually landed correctly.
Those two simple, evidence-based practices used consistently. They are foundational to making healthcare safer, more efficient, more effective, and frankly, more humane for everyone involved.
And it's important to remember, we all benefit from clearer communication from our healthcare providers and systems, especially in those high-stress clinical moments we talked about. So you, the listener, you now have the knowledge, the framework, to demand and identify a truly health-literate system when you encounter it, or to recognize when it's falling short.
Which brings us perfectly to our final provocative thought for you to mull over. As healthcare becomes increasingly driven by personalized medicine, complex genomic data, predictive algorithms, and AI-driven decision support systems, and the information itself becomes exponentially more complex, will our current ambitious focus on achieving universal health information fluency actually be enough?
Or is it possible that the sheer difficulty of navigating and interpreting that future data landscape will force us to eventually shift the focus?
Perhaps shifting away from expecting every individual to successfully grapple with that level of complexity, and moving toward systems that are designed to reliably make well-informed decisions for us, guided by our stated values and preferences, rather than putting the primary burden of navigation on the individual.
Will the complexity outstrip our ability to teach fluency, forcing a reliance on trusted system agents, whether human or AI?
It's a profound question about the future of agency and decision-making in healthcare. But you now have the full context, the understanding of this systemic shift, to think critically about the digital and informational systems being built around your health right now and in the future.
Definitely something to think about. What stands out to you? We hope this deep dive gave you valuable insights. We'll catch you on the next deep dive.